Hello, everyone. Thank you for joining us today for today's important discussion entitled CMS Opens Door for Pre-Release Services for Justice-Involved Populations, Healthcare and Justice System Implications. My name is Allison Hamblin, and I serve as President and CEO of the Center for Healthcare Strategies, or CHCS. I'm so honored to welcome you to today's panel focused on unprecedented new opportunities to provide coordinated healthcare coverage for justice-involved populations prior to and upon release. My colleagues and I at CHCS are particularly delighted to be co-hosting this webinar with our partners at the Council of State Governments Justice Center, who you'll hear from in just a bit. Following recent federal action by the Centers for Medicare and Medicaid Services, health and justice system stakeholders have new opportunities to work together to coordinate care and services for individuals who are re-entering the community from jails and prisons. California is the first state to have this opportunity, and other states are expected to follow in the months ahead. The approval of California's pre-release services waiver request is arguably the biggest opportunity since the expansion of Medicaid eligibility under the Affordable Care Act to promote safe and effective reentry following incarceration. We're so pleased to bring together today's panelists who will address this critical opportunity from both the health and justice system angles and examine the implications for stakeholders in California and across the country. Next slide, please. Before we dive into today's agenda and introduce our panel, we wanted to share a little bit of background on CHCS and the Council of State Governments Justice Center. CHCS is a national nonprofit that works to strengthen healthcare services to ensure better and more equitable outcomes, particularly for people served by Medicaid. We partner with state and federal agencies, health plans, providers, community-based organizations, and consumers to address obstacles that stand in the way of health equity for people facing the greatest disparities. More equitable care is a fundamental goal in addressing the healthcare needs of people in the justice system. Our jails and prisons are where so many of our society's inequities are manifested, and new pathways for providing coordinated access to needed health and social services upon release are an important step in addressing those inequities. I will now welcome some opening remarks from Aisha Delaney-Brumsey. Aisha is the Director of the Behavioral Health Division at the Council of State Governments Justice Center, where she oversees work addressing how the criminal justice system intersects with the mental health, substance use, and homeless systems, among others. Aisha, and next slide, please.
Thank you so much, Allison. Really, I'm excited to be here today. Also very excited to be here with our panelists and to be part of that discussion. So thank you to you and your team for working on this. So welcome everyone. Like I said, excited to be here. And as Allison said, my name is Aisha Delaney-Brumsey. I oversee the Behavioral Health Division at the Council of State Governments Justice Center. And for those of you who are not familiar with the Council of State Governments Justice Center, we are, like CHCS, a national nonprofit. We are a nonpartisan organization that works with communities across the country to improve the fairness and effectiveness of their justice system. We aim to reduce incarceration, advance health opportunity equity, and use data to improve safety and justice for people all over the country. The Behavioral Health Division specifically focuses on the goals of reducing criminal justice system contact for people with mental health needs, substance use needs, as well as people experiencing homelessness, and to connect them to the types of supports and resources that not only reduce the likelihood that they come into contact with the criminal justice system again, but also that aim to help them live full lives, full and well lives. So as Allison briefly touched on in her remarks, what we know is that people who are incarcerated and people who have had contact with the criminal justice system have very complex health needs. This is really no surprise, I think, to many of the folks who are on this virtual room today, but we've known for a very long time that the rate of mental illnesses in correctional facilities is 3 to 5 times higher than the rate in the community, while rates of substance use conditions are 12 to 15 times higher. And that doesn't even speak to the fact that people who are incarcerated have disproportionately high rates of complex physical health conditions, such as infectious diseases, cardiovascular disease, and more. We also know that the point of transition from incarceration and back to the community is a particularly it was a particularly high point of risk for people in terms of their health and their well-being. We know from research that in the weeks following release from jails or prison, people are at significantly elevated risk of death from overdose, suicide, cardiovascular disease, stroke, and much more. And we've known this, but despite this longstanding awareness about these high rates of needs, we also known that accessing care, while people are incarcerated, and particularly in that interstitial period as people are transitioning back into the community and returning home, that being able to access care and being able to access quality care is a persistent challenge, and one that we have not effectively solved yet. And the types of numbers I talked about are really borne out in people's lived experience. I was struck recently, we hosted a series of conversations with people who had a history of incarceration, as well as people who worked in organizations, health and social service organizations that are focused on helping people return home from incarceration. And we asked them about some of the biggest challenges they were experiencing, and over to a person, they talked about the challenges of accessing care. They talked about the difficulty of paying for care. They talked about the difficulty of finding an appointment, about finding a provider who had to respond to their specific needs. And those kind of barriers not only were hugely negatively impactful for their health, but we had people who talked even about to the point where they spun into crisis. They were experiencing significant suicidal ideation. So this type of work isn't just critical at kind of a high theoretical level. This is important for people's lives and their well-being and their families and their communities. We also heard from the providers that one of the biggest challenges that they have with supporting people at this moment is that there's frequently not steady and significant enough funding for the types of care that they'd like to provide, for the types of care where they're able to send people into jails, into prisons, into juvenile facilities to assess people's needs and connect them to care and to safety net providers as they're coming out. So that's why I'm especially excited about the work that California has been doing with the support of CMS and the federal government to really shift our ability in California to provide that care and to fund it through the 1115 waiver. So I'll leave it there and just say I'm very, very excited to start this conversation today.
Aisha, thank you so much for your partnership in pulling this together today, and for that important grounding and case making for why this is such a big deal. With that, I will just briefly go over our agenda today, if we can go to the next slide. As you know, we're principally here for a cross-system, cross-sector panel discussion. But before we kick off the panel, we're going to do just some high-level level setting on health coverage for people in the justice system, as well as a summary of some of the key components in California's new waiver. With that, we can actually go 2 slides ahead now, because I think we didn't get the agenda slide up there. Apologies for that. We can go ahead and jump to introducing our remarkable panel today, who collectively represent deep expertise and experience in both the criminal justice and healthcare sectors in California and nationally. And so really just delighted to have all of these folks with us today. In addition to myself and Aisha, we will be joined by my colleague Liz Buck, who is a senior program officer at CHCS and who leads our Justice Involved portfolio of work. So you'll hear from Liz in just a moment. We are also so pleased to have with us today leaders from both California's Medicaid, or Medi-Cal, and corrections systems. Autumn Boylan currently serves as Deputy Director for the Office of Strategic Partnerships within California's Department of Healthcare Services, and has been with the department since 2015. And Brenda Graylish is the Executive Officer of the Council on Criminal Justice and Behavioral Health within the California Department of Corrections and Rehabilitation. Previously, Brenda also worked at California's Department of Healthcare Services, so is perfect for a cross-sector conversation like this. And there she served in several positions overseeing both mental health and substance use disorder services. And finally, we're delighted to have with us Vicki Watino, who is Executive Director of the Health and Reentry Project, which is an initiative to promote public health and public safety, convened through partnership between the Council on Criminal Justice and Waxman Strategies. And Vicki previously served as Deputy Administrator of CMS, where she oversaw all policy and operations for the Medicaid and Children's Health Insurance Program. So please join me in welcoming our panel in just a moment. But before we do that, as I mentioned, we're going to do a little bit of level setting just on the landscape and on some of the key components of California's recently approved waiver. And with that, I will turn it over to my colleague, Liz, to kick us off.
Thank you, Allison. Next slide, please. So as Allison mentioned, really excited to give just a little bit of a primer on why this is so significant, and with a lot of gratitude to be presenting this in partnership with Autumn Boylan, who will be speaking specifically about the waiver in California itself, some of the nuts and bolts to kind of ground us in the broader panel discussion. So next slide, please. As we're talking about this population, I think helpful, as Aisha shared, to really talk about the significant healthcare needs of the justice population and the reasonings behind that, what leads to health inequities and healthcare complexities, issues like structural racism, including over-policing, housing discrimination, a lack of low barrier housing and services, and really a poor coordination across sectors and silos, including behavioral health, housing, corrections, social services, really contributes to the overrepresentation, disproportionate numbers of BIPOC and people with behavioral healthcare needs within correctional systems more generally. As Aisha mentioned, disproportionate rates of serious mental illness, substance use disorder, chronic healthcare conditions, and infectious diseases compared to the general population. So a sicker population, both going into the justice system and then when leaving. We find as well in terms of transitions to care that there are really compounding risks and needs that impact an individual's ability to get healthcare when they exit jail or prison. So significant rates of homelessness, for example, which can make it much more difficult to navigate bureaucracy, to get connected to Medicaid and healthcare, and really individuals managing significant needs when they leave a jail or prison. And then really want to highlight that this is a health equity issue that we'll touch more on in our discussion with the panel, but really significant inequities within the criminal, with those who have criminal legal involvement. So for example, Black men comprise about 13% of the population, but are 35% of those incarcerated. And as Allison and Aisha mentioned at the top, really that cross-sector partnership across, including community-based organizations and people with lived experience, are really key to developing solutions to the health for this population. Next slide, please. The movement of the healthcare system and Medicaid in having a greater role for the population health goals of this population, isn't coming in a vacuum. So there's been significant gains, of course, with the Affordable Care Act in terms of increasing coverage, especially for within Medicaid expansion states for this population. A movement in terms of suspending coverage rather than terminating coverage to create more seamless transitions for folks to have Medicaid when they leave jail or prison. Some states have requirements within their managed care contracts to provide in-reach services for individuals leaving correctional facilities. Precedent with the Support Act in terms of actually creating an infrastructure by law, a stakeholder group to provide insight and support in terms of looking at 1115 demonstration process to create better reentry planning for this population. And then the ASPE report, which coordinated alongside the CMS 1115 waiver approval in California, which was released in January 2023. Next slide. Just highlighting a bit of why this is so significant, and which Autumn will speak to some of the specifics within the 1115 waiver, but really it's the first time that a set of services are provided pre-release, 90 days pre-release through Medicaid. This partially waives the inmate exclusion policy created in the 60s, which prohibits the use of Medicaid funds for people who are incarcerated. There is given the fact that Medicaid has traditionally had a limited role for people who are incarcerated, there is quite a variety of variation in terms of the services provided to people. So it's a sicker population that has potentially less comprehensive services across the board. And as Aisha mentioned, that transition period is so critical for a population who's sick, including getting connections to behavioral health and other healthcare treatment. It's often the most dangerous time for someone being released into the community because of potential drug overdose or death. So really just so significant and historic. And I will, next slide, turn to Autumn to talk a bit more about why it's so significant in California. So Autumn, I will turn it to you.
Great. Thank you so much, Liz. And thanks for including the Department of Healthcare Services in today's presentation. As you've all said so far today, Liz, Aisha, and Allison, in your opening remarks, this is really a historic first step for the nation in California's approval. And we've really been, working with our partners throughout the state on designing California's 1115 reentry demonstration waiver, really focused on many of the things that you all have talked about so far today. And I think we can go to the next slide to start to get into some details. But in California, our goals for advancing this initiative very much align with those things that you all have already talked about during today's session. And we're really focused on advancing health equity, as Liz and Aisha talked about already today. The issue of poor health outcomes, and death for incarcerated people is a core issue for California. As in California, specifically, we just saw some national statistics, but in California, 28% of incarcerated males are Black, while only 5.6% of California's population represents Black men. Incarceration rates by race and ethnicity are significant, and disproportionately Black men and Latino men are disproportionately represented within these populations. So health equity is absolutely a driving factor in the decisions we made in designing California's waiver. We also want to make sure that we're improving health outcomes for the population, exiting jails and prisons and youth correctional facilities throughout the state. And we aim to do this by providing a targeted set of pre-release services in the period prior to an individual's release from a carceral setting to help aid in that reentry process. And of course, as the first state approved in the nation, we want to set an example, and we know that all eyes are on the state. And as we move forward in partnership with other states and CMS, making sure that we're thoughtful about successfully implementing this initiative is certainly at the forefront of our mind, to make sure that that we continue to help advance the nation in the right direction. The Justice Involved Reentry Initiative, as part of the 1115 waiver, as you see on the slide, is just one of the core components of our overall CalAIM Justice Involved initiative. And you see really in this puzzle piece image how all of those pieces fit together. So we didn't need waiver approval for the first component, which is to implement pre-release Medi-Cal application processes in correctional facilities throughout the state. And that already went live in January of 2023. So working with our correctional facility partners, as well as our county social services departments, to make sure that there are processes in place for correctional facility staff to work with the county social services departments to be able to get people enrolled into the Medi-Cal program by using a pre-release Medi-Cal application process in order to do that and make sure that people are set up for success, that they're enrolled in Medi-Cal, and that there are policies and procedures to account for release and reentry from the beginning. The waiver, of course, focused on the 90-day services that can be provided pre-release, and I'll talk about what some of those services are in just a moment, but that's obviously a significant component of the initiative. And really, we focused on that 90 days prior to release in our negotiations with CMS and in our discussions with our key partners, because that period of time really represents, you know, making sure that we have sufficient time to enroll the individuals in the Medi-Cal program, screen the individuals for access criteria for the pre-release services, assign a care manager who will help the individual meaningfully engage with the healthcare services. And we heard a little bit from Aisha earlier about how important that is to make sure people have those linkages to the supports in the community. It also gives the care management team an opportunity to build trusting relationships with the individual, to help develop with the individual a transition care plan, to coordinate care and services upon reentry. And it allows for some time as well for the care management team to stabilize and treat conditions that may exist, so that the individual is in a better place for reentry by having that stabilizing treatment happen prior to release. And then, of course, it also gives the opportunity for the pre-release care management team to make connections with the post-release care management team in the cases that those pre and post individual teams are not one and the same. The 90-day pre-release services really helps to pave the way, as I was just saying, for that reentry, which is what you see on the remainder of this slide. So making sure that there's a coordinated approach for behavioral health linkages and supports, including behavioral health clinical consultation, connecting individuals who are leaving incarceration with enhanced care management providers. And the enhanced care management benefit is a new benefit as part of the CalAIM waiver in California. Also linking those individuals to necessary community support, such as transitional housing, recuperative care, and other community supports that will help to address the social determinants of health and other needs of the individual. And of course, really focusing on those reentry and transition to providers through the Medi-Cal managed care plans in California, as well as to other community-based supports. Next slide. Specifically, California's waiver focuses on Medi-Cal or Medicaid-eligible individuals. So any individuals receiving services under the waiver must meet the Medicaid eligibility requirements in California, which you see on the left-hand side. However, in addition, those individuals also need to meet criteria for pre-release Medi-Cal services. So for adults, that means that they must be part of the Medicaid or CHIP eligibility group and meet one of the following healthcare needs. So they must have a mental illness diagnosis or need, a substance use disorder, a chronic condition or significant clinical condition, intellectual or developmental disabilities, a traumatic brain injury, HIV or AIDS, and or must be pregnant or postpartum. For youth, this is not the case though. For youth in youth correctional facilities in California, they will be able to receive all of the pre-release services and do not need to demonstrate a healthcare need for those services. All youth in correctional facilities who meet the Medicaid eligibility requirements will be eligible for those pre-release services. On the next slide, there's a review of the services that are included as part of the targeted set of pre-release services that will be authorized as part of this initiative. Pre-release services will go live in California as early as April of 2024. And we are spending the next year with our correctional facility partners by helping them to meet operational readiness requiremements for implementing this set of pre-release services. The services include reentry case management services, which is the foundation for the reentry demonstration, physical and behavioral health clinical consultation, which could be provided by correctional facility providers or community-based providers who are going into the correctional setting to provide those services, and can be done in person or via telehealth. We will also be reimbursing for laboratory and radiology services, medications and medication administration, including medications for addiction treatment, and services provided by community health workers with lived experience, as that is also a new benefit in California's Medicaid program. In addition to all of the services listed above, and that I just spoke about, the qualifying members will also receive outpatient prescription medications and over-the-counter drugs, as well as durable medical equipment. Next slide. As I said a moment ago, the pre and post-release care management is really the foundation of California's waiver program, and will care managers both prior to release and upon reentry will play a key role in planning and coordination and helping individuals navigate the healthcare delivery system in California. So the enhanced care management benefit, which is a new Medi-Cal benefit in California as of January of 2022, individuals who meet the CalAIM pre-release service access criteria will qualify for ECM, Justice Involved Population of Focus, and will automatically be eligible for the enhanced care management benefit. ECM is really a benefit that is designed to make sure that all of the healthcare needs of the individual are met through a care management team that is responsible for coordinating all of those healthcare needs across different providers within the delivery system to make sure that the individuals with high intensity needs are able to receive the care and supports that are necessary. Behavioral health linkages is also really critical to the success of the waiver, including making sure that there's continuity of treatment for individuals who receive behavioral health services while incarcerated, to make sure that we are facilitating referrals and linkages to post-release behavioral health providers in all of our Medicaid delivery systems in California, and that information is shared with the individual's health plan. And then there's also a requirement, of course, in order to make the enhanced care management and behavioral health linkages work, there needs to be a warm handoff from the pre-release care manager to the post-release care manager in the cases where they are not the same organization providing those services. But part of that is also developing a transitional care plan that will be shared pre and post-release and then carried out as the individual re-enters the community. So during those pre-release care management meetings, the case management team will help to develop those trusted relationships, develop and review the plan with the individual, and identify any outstanding service needs so that immediately upon release and re-entry, the individual can begin to get connected to those community supports such as housing or any other services that may be needed. Next. Lastly, and as a part of California's waiver, the Centers for Medicare and Medicaid Services also authorized $410 million for our Providing Access and Transforming Health Capacity Building Program, or PATH Capacity Building Program, which is really focused on providing planning and infrastructure investments for correctional facilities and key partners to be able to stand up the pre-release services that will go live beginning in April of 2024. So this program will support the correctional facilities directly, as well as their county behavioral health agency partners, community-based providers, probation officers, sheriff offices, and others, and to ensure that they're able to implement this program successfully and meet all of the operational readiness requirements. And those dollars will begin to go out in the coming months so that our correctional facility partners have plenty of time to be able to start to implement the necessary infrastructure and capacity components that are needed to go live with the new waiver program. DHCS is getting ready to provide detailed guidance about the PATH applications. We are also developing a policy and operational guide that will be shared with our partners in California to help them understand all of the various requirements that go along with the waiver and to provide guidance and to support the correctional facilities for standing up this program. I think with that, I will turn it back over to Liz. Thank you.
Thank you so much, Autumn. And I'll just go to the next slide, Emily. And for emails, we'll leave that there and put it in the chat box too, but next slide. Very quickly, I just want to share that, you know, as California is leading the way, there are other states, about 14 others that have applied and are waiting. So there's obviously more to come here and really shapes kind of the opportunity discussion that I know Allison will be discussing with our panelists right now. So I will turn it to her to get us started there.
Autumn and Liz, thank you both so much. We could do an entire panel easily on a deeper dive into all of the details that both of you shared. But for now, we're going to leave that there and jump into our panel discussion. And I'm just delighted to kick this off, and we'll invite our panelists to join me on camera so we can begin our discussion. I see that many of you in the audience have already found the Q&A button on the bottom of your screen, and thank you for continuing to submit questions. I see a lot of questions coming in, which is not surprising, and we may kind of curtail some of our planned questions that we begin with to try and address as many of the questions that you are sending in as possible, and we'll do our best to answer those one way or another, so thank you for bearing with us. So panelists, welcome, and Brenda, I'm going to start with you. So we just heard a lot of detail from your colleague Autumn, and clearly there has been a tremendous cross-sector effort that has gone into a thoughtful, very intentional design of an array and continuum of services, both pre and post-release here. And so I'm curious, from the justice and corrections system perspective, what do you see as the biggest opportunities moving forward with new coverage of these services?
Well, thank you so much for having me here today. I mean, first off, I just want to congratulate DHCS again, because it's such a huge win and just such a huge accomplishment. And, you know, also very proud of our correctional partners for jumping in. It's not a tough or not an easy thing to get into the Medicaid / here in California Medi-Cal space. But, you know, being open to those conversations and engaging. I've been in a lot of the work group meetings, and our justice partners have been right there, just trying to absorb and learn and help DHCS work through this, and then also CMS for having this vision and support. So there's so much going into this. I mean, you can just see that's just like a few sentences of all the big players, but even bigger is going into the implementation. So you know, as the presenters have already mentioned, this is a population that has experienced extreme inequities over the many years, and you know, the connection to care has just been really tough. And so and also there's just not a whole lot of trust you know, in with this population in wanting to seek care. And so there's a lot of factors going in, and you know, traditionally, because of the exclusion, we have folks coming out of incarcerated settings, and I always say they kind of fall off a cliff, because there's that period of time before their Medi-Cal's activated, or they're selecting a Medi-Cal managed care plan to enroll into. So there's this gap, and this is where we see people starting to, you know, experience relapse or overdoses and deaths. So I mean, this is just such a tremendous opportunity to really have a strong coordination of care from you know, the incarcerated setting into the communities. I will say definitely, as Autumn had mentioned, with the community health workers and And also in our behavioral health plans, bringing in behavioral health peers, certified peers. These are also it's just so many moving pieces at a time, each one of them a game changer in and of itself. But, really having that linkage with community health workers and peers to help foster that trust, being those, really strong, credible community messengers. And so, really being able to get those linkages going and maintain. That's another piece of it too, is maintaining it, because you might engage someone for a moment, but not be able to maintain. And that's where we see folks falling off. We at CCJBH have had a project going with DHCS for quite a few years now called our Medical Utilization Project, where we look at individuals who are releasing from California Department of Corrections and Rehabilitation, and we track their Medi-Cal enrollment and behavioral health services utilization for individuals with identified behavioral health needs as they transition out of prison. And at best, it's 50% in a year, depending on co-occurring mental health and substance use disorder, and mental health only tends to hit about 50% of them. When it goes to SUD only, which is the greatest part of our population releasing, it's about 30% get one service. And then it drops off even more when we see engagement, and we define engagement as 5 or more services. And so, really getting that penetration and those engagement rates, that's something we have some baseline data on, at least for the prison system. But we want to, we'll be able to track that and see if we see increases with the implementation of CalAIM with the 90-day in reach.
Thanks so much for all of that, Brenda. And we'll come back to some more of those details in California in just a minute. But now I want to dial this up a bit and take a little bit of a national view. And so, Vicki, I want to turn to you first. Liz showed a slide a moment ago showing a number of the states that are kind of waiting in line for similar requests to be reviewed by CMS. And so in the wake of California's approval and the understanding that CMS will be likely to release guidance in the weeks ahead, what advice do you have for states, or what insights would you share in terms of what other states might be preparing for, or how they might best prepare for the road ahead to the extent additional approval could be granted?
Well, first, Allison, thank you to CHCS and to the CSG Justice Center for bringing people together around this critical topic, and to California for leading the way. Where we stand now, I'm struck by the degree of alignment between federal leaders and state leaders, and the shared sense of opportunity at all levels of government around the goal of creating greater continuity, greater access for people leaving the justice system, and underpinning it all, the goal of health equity. So we stand at this moment where you just see a lot of consensus around the direction that the health system needs to go with regard to people who are leaving incarceration. And as we all await federal guidance, national guidance for all states, and we kind of look to California as an indicator of what might be coming, I think it's a very strong indicator. I think probably both California and federal officials at CMS spent a lot of time thinking about the specifics that California presented to them. And so I think as states are trying to anticipate what might be coming, California is a really, really great starting point. That said, we don't know everything yet, and I have a couple of ideas of things that state officials can do while they wait for federal guidance, which I hope will be coming soon. And the first is really to take this opportunity to think about what is the best way of moving the needle of the health for this population. It's very exciting that we have this new energy and momentum and approaches, but I think we all have to recognize that the needs of people leaving the justice system have been on the back burner for a very long time. We haven't, as a health system, yet taken the initiative to figure out the best ways of engaging them or meeting their health needs. There's a lot of work that can be done along those lines, including critically talking directly to people who've experienced incarceration themselves to better understand their take on the systems that interact with their lives and on their health needs. The second is stakeholder engagement. We always say with any Medicaid change that stakeholder engagement is critical, and it is extremely critical when it comes to these new policies, which are really bringing the health and the justice system together for the first time. And that's why this webinar is so important, because CHCS and CSG are bringing together cross-sector leaders. It's been a key tenet of my work through the Health and Reentry Project to really get these systems talking to each other, speaking the same language. And again, let's not just make this about systems and power players, but bring people with direct experience directly to the table. Finally, to think about what will Medicaid's role in overseeing these services be. Carceral healthcare has operated outside of the healthcare system. And when states take on the responsibility of covering pre-release services through Medicaid, they are also taking on the responsibility for making it all happen and bringing a lot of the same approaches that have been successful in Medicaid and other healthcare programs to bear. And so I think it's also worth really actively planning for what will a state Medicaid agency's role, what will a managed care organization's role be in overseeing service provision.
Vicki, thank you for all of that. There's so much in there that I hope we have time to explore further, and really just appreciate you laying out those recommendations in those categories, particularly for our states who are joining us today. Aisha, I'm going to turn to you for a second now. You started us off today really talking about the opportunity to advance health equity that this approval and hopefully the ones that follow provide for all of us who are working on these issues. And I'm curious if you have reflections, based on your own work in this area or in listening to the comments that have come thus far in the session. What's it actually going to take for these efforts to really sort of achieve that goal of advancing health equity, providing more equitable access to services for justice-involved populations?
It's a great question. Excuse me, Allison. It's a great question. And, it's something Vicki just said kind of stuck in my mind as like a great response to this question, which is we are in this moment when there is an incredible amount of recognition amongst federal, state, and local leaders that now is the time to address the health needs of people who have been incarcerated. And that has been something that's been on the back burner of people's focus for a very long time. And you do see that reflected in how we've paid for those healthcare services for so long. So what we know is that the cost for healthcare in correctional facilities is astronomical the way it is in the community. But unlike in the community, the responsibility for overseeing those costs, for making decisions about the quality and scope of healthcare services, for how much is invested in that, really falls not to the healthcare system in most places, but to the correctional system. It falls on sheriffs and departments of corrections. And the result is that we have a system where the decisions about healthcare are being made by correctional leaders. And those are just decisions that they then need to weigh against their other pressures and pulls, like thinking about their security staffing, thinking about the physical plant of the building, and all the other things that they have to manage within what are often very strapped budgets. And so what you see is across the country, correctional systems that often are being overseen or provided healthcare through not for-profit corrections healthcare providers. Too often see that people who are incarcerated are asked to defray the cost of healthcare by paying what looks like small copays, $2, $5. But when you think about the fact that average pay, if people are being paid for work in corrections, is 15 cents on the hour, 70 cents on the hour, those are huge costs to have people who are very, very sick and in need of care pay. And you'll have to excuse me all, everyone. Sorry for coughing. I'm still getting over a little bit of a cold, so bear with me. But, I think about when I was in Nevada and I was talking to a jail administrator at a relatively small jail. He was talking about the fact that he was trying to juggle within that jail the need to provide care, which he wanted to do, but he was trying to figure out, how do I do that when one of the last providers in my area just left? The other provider is not interested in providing care in my jail. I'm dealing with this significant shortage of corrections staff. We have this major repair we need to make, and I'm doing it all in one budget, and doing that with relatively little coordination from my local healthcare safety net. And so I see that as the kind of challenge that a lot of corrections administrators and a lot of correctional facilities are trying to tackle with relatively little support from the healthcare system. Or maybe support is the wrong word, but it hasn't been as much the responsibility of the healthcare system. Something like this 1115 waiver, it really does shift the onus of responding to those costs and responding to those needs back into the health system in a way that's meaningful, both in terms of reducing some of that burden on the correctional facilities, but also in terms of putting back into the responsibility of the health system the need to make real decisions about how we support some of the most vulnerable people in our communities and how we ensure that they are healthy and well, and that we are providing that care. And so that, I think, is one of the ways in which this kind of shift can support equity. Not a guarantee, though. It requires that jurisdictions do things like make sure that when they're providing care to people who are incarcerated and looking for the types of supports, that correctional facilities are coordinating and getting care through organizations that have the interest and expertise to work with people who've been incarcerated. That is a population that they care about and are interested in supporting, that they understand the complexity of those needs, not just the healthcare needs and not just the behavioral health needs, but the need for the impact of stigma and trauma, the need for connection to housing, that they're building out the level of support that's required. It also means thinking with people who've been formerly incarcerated about what they need and when. I think we make a lot of decisions about the types of healthcare services we're going to provide in some places without asking people what were the very first things you needed when you came home. And so shifting the responsibility so it's co-managed between healthcare and corrections, but that the weight of the burden of providing for that care and making decisions is moved into the health system, and that the health system does it in such a way that keeps an eye on the particular needs of people who are justice involved and involves them in the building out of those services, is one of the ways that I think we can see a real shift in terms of equity going forward.
Thank you for that, Aisha. There's a ton in there that I think is really meaningful. And I think all of that sort of highlights that this is not just about the ability to use federal dollars to pay for services, but really the change in cross-sector accountability and relationship here that really changes the dynamic and priorities for folks in both systems, and really ups the ante for the collaboration that folks have spoke to already in this discussion today. So thank you for that. And speaking of cross-sector perspectives, Autumn and Brenda, I'm going to turn back to you for a moment. It's clear through what we've talked about thus far that, again, immense planning has gone into this. And I was really struck, Autumn, by the timeline. We still have a year of planning ahead and capacity building with a lot of thoughtfulness around, again, not just what the services are and not how they're going to be paid for, but what do folks have access to when they do reenter the community, and how do all of these pieces fit together, and what do our various partners across systems need support with in order to successfully implement these new services. So in light of all of that, and as much work as you have before you, what advice would you give other states who are not as far along as you are right now? Maybe they've put some thought into what a service array might be. Maybe they have started their own negotiations with CMS. But knowing what you know today and knowing sort of what you've done thus far and all of the decisions and steps waiting ahead of you, how would you counsel your colleagues in other states at this moment who are interested in pursuing a similar path? And Autumn, I might start with you and then turn to Brenda.
Thanks, Allison. Yes, even with the waiver approval for California coming in January, we still have a lot of work to do. So of course, it was a lot of work to negotiate the waiver and to figure out the special terms and conditions that would apply in California's waiver, and negotiate all of that with CMS. But really, I think the work that we've done with building relationships with our partners across the settings, that's really been the critical factor to getting us where we are today, but it'll also be the most critical factor to take into consideration as we move forward. Building relationships between the healthcare delivery system and correctional facilities, making sure that community-based providers are a part of the conversation, making sure that the health plan payers at all of the levels, that that the correctional facility partners at all of the levels, that associations are part of the conversation is really key. And from our experience, building those relationships is really at the forefront of the work that we've been doing for the last couple of years, and continues to be a key part of our strategy for implementing this waiver successfully going forward. So, really focusing on the policy and operational design, having that work that we do with stakeholders and key implementation partners around those pieces inform our waiver negotiations with CMS has really been critical. We have a justice involved advisory group that we convened in California that has a diverse set of stakeholders across these different systems and partners to help inform this work from key sectors, including counties, prisons, jails, providers, consumers, health plans, policy organizations, our youth correctional facility partners, and partnering with Brenda and her team and others at, in the state level has been critical. And there's, still work to do across these various sectors to make sure that we're building up the appropriate infrastructure to support this initiative. So really focusing on building those relationships, having regular channels for input, whether it's an advisory committee or otherwise. In addition to our advisory group, we also meet regularly with key implementation partners across the state to help inform our work. We've built relationships with a small group of folks that can be trusted partners to test new concepts and ideas. And I think, building those relationships is really key. We also learned through the process that targeted one-on-one technical assistance is necessary. So we've been working with correctional facilities, county social service offices, the county behavioral health agencies, Medi-Cal managed care plans, and other key implementation partners on a regular basis, in sometimes in cohorts together and sometimes in cohorts separately, to make sure that we are preparing each of the various implementation partners for implementing this initiative, and they all have different needs across these different systems. So making sure at the state level we're meeting their needs, but then also making sure that they are working together locally to build out that local infrastructure is really important. So we've done a lot of work with our key implementation partners and meet with them multiple times a week on various implementation issues. And we work together to develop policy, vet drafted policy that our team develops with a cohort of prison and jail representatives to make sure that what we design will translate operationally. For example, we're still working with our county partners around this policy and what that looks like for jails across the state, where a majority of people who are incarcerated in jail settings are in there for a very short period of time. So, fewer than 48 hours in a lot of cases. So what does this policy look like? Obviously, it's not a full array of services in that 48-hour period, but how do we make sure that we're translating the larger policy to work for the various correctional facility settings? And again, even within jails throughout the state of California, we have larger systems and smaller systems in each county. And so making sure that we're thinking through kind of the operational considerations for all of our partners across the state so that we can implement this initiative statewide is really critical.
Thank you so much, Autumn, and tremendous complexity in all aspects of that. And Brenda, Autumn, talked to some of the challenges and unique considerations in various correctional settings. I'm curious for you to add any thoughts to the mix from where you sit here.
Yeah, so I mean, +1, 2, 3, and 4 to what Autumn said. There's so much in terms of that relationship piece that just should not be underestimated, particularly in terms of like organizational cultures. Like, I mean, there's a lot of cross systems education, like just that's needed just to set a basic foundation for those communications to take place. And it takes time and energy to do that. And I'll just give you an example. I mean, just some things in that I've come across just in the last couple of years. We've been having these conversations in California. Using a simple word as services means something different in the correctional space, means something different in the healthcare space. Even housing, they have services, all different. And I've seen where we've gotten into conversations where we're working cross system on particular projects or assignments using the same word meaning two different things, and you get 4 to 6 months down the road and go, wait a minute, I didn't realize that's what you meant. And that really has implications for roles and responsibilities and who thinks, who's doing what. So being really careful about those kinds of things. I'll give you another example. Healthcare is not super familiar with the concept of evidence-based corrections and criminogenic risk and needs, and that there are interventions to address those needs that get identified, and what any of this means. It's like I've said that in different healthcare spaces, asking people to raise their hands if they even know what evidence-based corrections are, what criminogenic risk or criminogenic needs are, all that, and I might get a couple hands. And this is something even in the behavioral health space, even when I was working at DHCS, trying to promote that, because I had been working in the corrections space before coming to DHCS. So I got schooled on it myself. It even took me a while coming even from before corrections to a healthcare space. It took me a good year to realize I was talking about something different than the correctional folks were talking about in terms of treatment. So really just want to say the importance of those cross-system educations is also helps to build trust. And really everyone just having some grace with one another for the learning curve, because it's a big one. And these are very complex systems. And everyone's having to move so quickly to get this done and get this off the ground. And the need is so pressing, but just being able to have grace with one another. I will definitely go with what Autumn said on the stakeholder engagement. I was at DHCS when we first launched the CalAIM as a proposal, just these concepts we were putting out. And to think about where we started back then and what it looks like today, I mean, it really just went through a morphing over time with just wonderful stakeholder engagement. And I will say DHCS gave stakeholders a lot of time to think about things. So it wouldn't be like, oh, here's a proposal, put it out for like a week, and then everyone's scrambling to return responses. It was very thoughtful, and I think that really helped to shape it into a very good product, which got put forth to CMS. And I think all those infrastructure costs, if I had to give, to other states that are thinking about that, building in costs for developing this infrastructure, this is not inexpensive. This is a lot, with the idea that you're going to have bigger cost savings down the line and better outcomes. And so, really building in early on that the recognition and the actual allocations for supporting that infrastructure development. And housing's been really key in this. I know we haven't talked a lot about community supports, but that's pretty big too, that CMS has approved some of the housing services. And then that's really pushed a lot of conversation and bringing housing partners into this space. So now it's not just criminal justice, behavioral health, but now we've got housing at the table, who's really in the game and talking. And now social services, I'm seeing even brought into these conversations more and more. And so really trying to think that through. And then the workforce, I'm seeing it in the comments, but California has also really been making some big investments in terms of building workforce. We have a Department of Healthcare Access and Information that's really focused on building out behavioral health workforce in California. And DHCS also has some some behavioral health workforce initiatives and projects going as well. So there's been a big focus and concentration after, with that recognition that we just don't have enough people. And that's another thing where peers and community health workers are just absolutely instrumental to be able to ease some of the work off of the clinical staff, and so that they're able to help with certain things that free time up and help us use our resources better. So those are the things that I would think to have other states really keep in mind as they're thinking to plan through this.
That's great, super helpful, and just underscoring the need for timeful planning for all of the things that you just referenced. So thanks for that. Before we open it up to our questions from the audience, which, wow, a lot of questions have come in here. So we will do our best to get to a handful of them. Vicki, I want to tee up one more question for you, and that is, we've been talking a lot on the healthcare side of this about the role of state agencies and state officials and Medicaid or Medi-Cal in particular. But there are a lot of other healthcare stakeholders that need to be at the table, and it sounds like who've been engaged in California's planning initiatives. If you think about healthcare providers, healthcare systems, managed care plans, what would you be advising them to anticipate in terms of their role and how they can be good partners in launching these new services for justice-involved populations?
Great question, Allison. So the first thing I would say to insurers and to providers is this is a population health moment. Many of us who work in healthcare have been looking for ways to address common conditions, asthma, high blood pressure, diabetes, all of those conditions, as well as mental health and substance use disorder, as you've heard, are more prevalent in people who are in the justice system than they are in the general population. Yet we have not really fully acknowledged the approaches that we need to take with people leaving the justice system. We have not made them an active part of the work. And this is a chance to do so, to really develop some approaches that generate tangible population health goals. That said, I think that providers and insurers have to come to the table ready to do the work. And to really think carefully about the needs of this population. We asked 70 stakeholders last year interested in changing health and reentry, what would really move the needle? What is it that's needed for this population? And here's what they said. Primary care with strong connections to behavioral health and social services at release, active patient engagement and patient navigation, and widely available trauma-informed approaches because so many people in the justice system have experienced trauma. And so I offer that to the field of providers and plans, particularly who are getting ready to roll up sleeves and breathe life into these new policies and make them a reality, that there are approaches that people have identified, stakeholders have identified as being extremely promising in terms of realizing population health for this population.
That's great input, Vicki. Thank you for sharing that. Liz, I am going to turn this over to you with a wish of good luck for getting through a lightning round of however many questions you can cover in the next 12 minutes.
Thank you. And this is so fantastic. There are no shortage of questions. We tried our best, but I think there's a few California specific questions, and I'll try to pepper throughout on some of the broader national work. But there were some questions specific. I think Brenda and Autumn kind of describe a little bit about the 90-day window, like particularly the difference between jails and prisons and how you all are thinking about this. The question was, how do you determine the 90-day window for inmates in county jail? The majority of the people in our county jails are non-sentence inmates without a definitive release date. Probation and parole violations make up the majority of the population. So wondering, Brenda, if that's something you might feel comfortable touching upon, or Autumn.
I am, but I will defer to Autumn.
Okay.
As DHCS.
That is something that we've definitely heard from our partners that is a challenge. that oftentimes, particularly in jails and youth correctional facilities, but also sometimes within the prison system, that the individual's release date is not a settled date that is fixed in time and therefore predictable. So it is certainly something that we have heard and are working to address, in terms of the approval that was received in our waiver. The waiver does limit the period in which we can deliver the targeted set of pre-release services and seek federal reimbursement to that 90-day window. And so we're trying to, as part of our policy and operational guidance, which will be coming out in the next several weeks, frame out how to address this issue of the release date being unknown and what that means operationally in terms of, when services can be reimbursed for individuals who may not have a fixed date. And then also other questions that have come up related to that is, what happens if you have a date, but then that date changes, because that also happens. And so we have started to think through with our implementation partners, what the guidance needs to be like when an individual is incarcerated for fewer than 90 days, at what point in the process and the timeline can certain things be done. So, we don't necessarily have the answer to that today, but it is certainly something that has come up regularly and that we are working with our partners to address through the guidance that will be issued, like I said, in the coming weeks.
That's really helpful. And another question. So, Adam, I might not be giving you a break for a moment or two, but I promise I will. So Adam, housing has come up as a few questions. So someone specifically asked if managed care plans are going to be able to assist individuals to access social supports, including housing after leaving a correctional facility.
Yeah, so as I mentioned during my presentation, all individuals leaving a carceral setting will be automatically eligible for the enhanced care management benefit, which is a part of California's CalAIM waiver. Outside of the specific 1115 approval, it's a part of our 1915B waiver that was approved by CMS. And so as a part of the enhanced care management benefit, the enhanced care management team or individual providing those services will be required to help connect the individual to all of the services and supports that they may need to address and maintain wellness, right? And so that would include linkages to housing supports that may help to set the individual up for success. We also, as part of our 1915B waiver, and in part as part of the 1115 waiver that was approved for our CalAIM initiative, also have access to an array of community supports or in lieu of services that were approved that can help to provide some support for individuals. And there's a set of 14 different community supports that will help link individuals to kind of necessary supports such as recuperative care. We're also working on a waiver, an amendment to the waiver around transitional rent and support there. So certainly it is a part of what we're doing in CalAIM to make sure that people are connected to appropriate housing supports in their community.
Great, thank you.
And if I could just add, with that's at the 90-day in reach, one of the things that we at CCJVH have been promoting for the last several months is, enhanced care management and community supports went live last year for for all the counties in our state, but definitely by July 1 of last year. And there's populations of focus that many of our justice involved qualify, will meet. So things like substance use disorder, serious mental illness, homeless, at risk of homeless. And so what we're trying to do, and it's kind of paving the way, it's kind of like, think of it like a phase 1 almost, is like trying to get these partners working together with what's available in the community today. And that helps kind of start getting that cross-sector relationship going. So there's things that can be done today and things that are being planned on the horizon. So just in terms of other states, when they're thinking about this, kind of easing into it in a very similar fashion.
That's great. And I can open this up to Vicki and Aisha too as well. I think there was a question related to the role of mental health providers and being really important partners. So curious, just given obviously your work in this area, but also the reality of shortages of mental health professionals. Are there strategies or sort of call to action that you would provide, just given the significant mental health needs of this population, as maybe more states are anticipating potentially these new services for folks leaving jails and prisons? Leave it. I don't know, Vicki or Aisha, if you feel comfortable responding to that question.
Well, I think the ability to connect people to mental health services is going to be essential to the success of this initiative. And, I anticipate it being an implementation challenge for California and the other states to really make those connections seamless. And underlying all of this is a real need for seamlessness and to develop systems that really support the person and do the work for them in accessing services, particularly behavioral health services. I think it's really promising that California has dedicated already a lot of attention to developing the behavioral health workforce. It probably goes without saying that that particular workforce has been under extreme stress under COVID. And so the need for winnowing in and really developing community capacity around behavioral health is key. I would suggest, where there are workforce shortages, really targeting efforts to communities where rates of incarceration are the highest, because they have historically been overlooked. Where behavioral health services are available, they tend to be more available for higher income, privately insured people than for lower income people. And then finally, states vary. So pivoting away from California, the national picture, really vary in the extent to which they offer a broad array of mental health services through Medicaid. It's one of the areas of greatest benefits variation in states. So I'd also really encourage states to look at their continuum of community-based behavioral health services, and as they move forward with waivers, to really make behavioral health a robust part of the continuum. It's also, the last thing I'll say is, a key strategy for keeping people out of prison and jail. And as promising as reentry is, we should not lose sight of the need to expand access to community health and behavioral health services to better meet people's needs so that we can help avoid justice system involvement to start with.
I think I completely co-sign all of that. And I think the only thing that I might add in the 30 seconds, while states and jurisdictions are thinking about that continuum that Vicki spoke of, we're seeing a lot of jurisdictions also think about the continuum of the different types of providers and the different types of support and the people who are supporting. And so we're seeing that one way that jurisdictions are trying to solve the behavioral health provider shortage is to really think about community health workers, peers, other types of specialists who are not your traditional behavioral health providers. I think there's a lot of benefit because for like engaging and connecting people, but I always also warn folks that those frontline staff are the kind of the backbone of our systems. They are the most underpaid, least supported, and they do a very hard, difficult job. And so as jurisdictions are thinking about that kind of expansion, to really also think about how they can make sure that they're doing so in a way that supports those workers to do the critical work of connecting people and to providing that kind of more non-traditional behavioral health care support. So.
Clearly, some love from the audience on those remarks in particular. Our time today flew. There are so many questions that we would love to have more time to ask you all, but we will look for another opportunity to do that. In the seconds I have left, I want to thank our amazing panel. Thank you for spending time with us today. Thank you to our colleagues in California who have established this model, and to your partners at CMS who have worked so closely with you in recent months to launch this effort. Clearly, so many of us are watching, and I was really struck by the puzzle piece slide that Autumn shared earlier of, the continuum of services that are part of this package in California, and then the comments more recently about how all of the broader pieces need to fit together here, the behavioral health workforce, the workforce more generally, housing services, and so forth, and really just all of the collaboration across systems and partners and stakeholders that really needs to come together to make sure we're speaking the same language and really thinking through all of these critical implementation details. So panelists, thank you so much for lifting up those considerations for us today, for getting this conversation started. There's clearly much more to talk about and to learn from you, and we're grateful for today's opportunity. To our audience, would appreciate if you have a moment, an evaluation will pop up. Let us know what would be helpful on this topic in the future, and we welcome the opportunity to have more discussions like this. And lastly, Aisha and our colleagues at the CSG Justice Center, it's been a privilege and pleasure to do this together. Vicki mentioned earlier, it's just a reflection of the need for cross-sector collaboration on these issues, and what a joy it is to have you all to partner with in these conversations. So thank you, everyone, and good luck with this implementation, our friends in California, and we look forward to rooting you on from the sidelines. Take care, everybody.
Thank you.